No.
Hello, good morning, colleagues. It seems we lost Dabo there for a second. Am I the only one that can't hear him?
Well, I'm here now.
Okay.
I'm here. All right. Yes. So I was saying that I was handing over to you so you can take over. But while we are doing that, please introduce yourself using the chat box, your name, organization, connection, or location. So let's start doing that while Emeka can take over as our moderator. Thank you.
Thank you so much, Dabo, for that wonderful use. My name is Emeka Ogwano. I manage media relations for NCDC. And it's my pleasure to be here with you. Thanks to the EIE team. They've been doing quite a lot. Thanks to the OAPs and partners. We hear so much about what you do. We are so happy to be here. We are joined by some colleagues from NCDC who would introduce themselves shortly. But we are so happy and look forward to hearing from you all. Earlier was slightly modified, and we want to hear from you. In fact, after the objectives, that's what we'll be taking next. I'll explain shortly. While I can see the chat box, people are introducing themselves. Please, let's keep that going. Without further ado, we do not want to waste any more time. We've already spent 10 minutes, and while we continue to admit the other participants, let's take a look at the ground rules. Please let me know if we are not familiar with this. I know that we've had a couple of Zoom sessions. It's this COVID, one of the good things of COVID. Increased frequency of virtual activities. So I would not want to bore you with the ground rules. It's pretty straightforward. You might just want to advance to the next item on the agenda, if we are all okay with that. And also, please, let's use the, if you want to speak at any point in time, kindly raise your hand. We're all muted now by the host. So we'll move straight to the opening remarks, which will be taken by the head of the Risk Communications Division of the NCDC, Dr. Yaya Disu. Dr. Disu has been online for a while now. Dr. Disu, please, we want to hear from you. Thank you, sir.
Okay, thank you, Emeka. Good morning, everybody. And good morning, the organizers of this program, particularly the leadership of VIE. I want to welcome everybody to this meeting on behalf of the Director General of Nigeria Center for Disease Control. And then we thank you all for sparing time out of your busy schedule to participate in this meeting, especially the gentlemen of the press, people who have been anchoring programs on air, who have devoted time to ensure that they allocate time and they give attention to COVID-19, they enlighten the public. And we appreciate you for all this. Where we are today because of your efforts. And then the reason we're here today is for us to interact, learn from each other, and then also familiarize you with what we do. And this is very important for the response and for every one of us, because the only way to overcome COVID-19 is by giving people information they need and encourage them to take the necessary actions and adopt the required behavior. And I want to say welcome again, and I wish us fruitful deliberation. Thank you.
Thank you so much, Dr. Jason. Thank you. That was very
Sorry, is somebody talking? I can't hear anyone.
No, Dr. Disu, no one is talking. Yeah, I'll take it over. I'll take over from here. Please, can you see my screen?
Yes, we can.
All right. So self-introduction that has been going on in the chat box. If you've not done so, kindly do so. Objectives, I'll take this. Permits me to take the training objectives. So first is, like I mentioned, we'd like to hear from the EIE team. We'd like you to share your experience on COVID-19 public communication and media engagement. Next, we'd want to familiarize all OAPs with terminologies, resource materials and operations of the COVID-19 response. We'd like to strengthen the risk communication capacity of the OAPs to deliver content that would help listeners make informed decisions about their health. I mean, I believe this has already been ongoing. In addition to knowing how it's been done, how the experiences, challenges, we also want to strengthen your capacity in that area. Lastly, but not the least, we'd like to identify challenges in factual reporting for COVID-19. So we'll move ahead. So just before Dr. Disu takes
Emeka, you are fluctuating. I'm not sure whether I'm the only one who's not hearing.
the public health response. So sorry about that. So Dr. Disu will take us through the public health response to COVID-19 from the NCDC's perspective, after which he would take us through the risk communication strategy, the national risk strategy for the COVID-19. But if we have any question at any point in time, even before he's done with the presentation, we can make use of the chat box just like we're doing for to introduce ourselves. Thank you so much. Dr. Disu, please over to you.
I will have wished that we listen to our participants that have been acquiring programs to learn from them their experience as you wrote in your first objective. And that will really help us in knowing where to emphasize during the presentations and our engagement. So if, I don't know, Emeka, maybe we can be flexible in implementing the agenda as long as
yes,
feel,
please. Yes.
Okay.
Yes, that was actually mentioned. Yes, please. We'll take it from here. I actually spoke to Dabo about that, and please, I would hand over to Dabo to moderate this aspect. We would like to hear from the OAPs. So thank you,
All right.
Dabo. Yeah, thank you.
All right. So good morning, everyone, once again. So yes, we want to hear from you, those of us that have been moderating the conversations, anchoring, organizing them, our partners and OAPs. We want to hear from you and how the experience has been so far. I mean, just tell us what you've seen. I mean, you are the ones in Niger, in Kano, in Kaduna doing this every day or every week rather. So just talk to us on what your experiences have been, what feedback has been, or what feedback you've been getting from people, and how that has influenced your work in your different states. So please, the floor is open. Just speak, and then we can listen to as many as possible before we go ahead to the next session. So who wants to start? Just feedback from your states. Okay, all right.
Hello.
Yes.
Dapo, can you hear me?
Yes, Mukhtar, I can hear you.
All right, my name is Mukhtar Modibo. Work at Code. I've been the one handling Abuja and some part of Kaduna and Taraba. Can you hear me?
Yes, we can, clearly. Go
all
ahead.
Right. So I think for me, first of all, I would not like to mention challenges. The first issue we've had was, around bringing guests. So most of the time, some guests expect normal transport stipends. It has been a problem, but we were able to find a way to just modify it. Sometimes we do call-in programs, and sometimes we do we do a normal bring them to the studio. Sometimes I go pick them up from where they are to bring them to studio, which is good. And topics, yeah, getting topics has been some major point, getting the required topic that is expected of us all, and then for citizen to really flow with the program, getting the kind of catchy topic that will make citizen to be part of the program has also been one of the things we've been doing. So challenges, our challenge, one of my major challenge, it has to do with call from during the radio program. We've discovered that almost 92% of the people that have been calling are guys. Women don't really call. So I don't know what has been the problem. So we try to bring we try to bring some issues around bringing gender-based violence, issues that has to do with women, from gender issues, domestic violence and other things, to bring it to women, and like to see if they can really talk. Yes, seen some, concern like calls and what have you. People have been calling, but majorly they are still the guys that majorly call. And then the second concern is around the last publication that DAPO shared about the press release that NCDC, that's the Nigerian Center for Disease Control, sent out about the news of people from outside the country coming to Nigeria, paying some certain amount of money before they are being tested. So I think we had a conversation with that on the radio. I'm sure Bumi is here, our OAP at Kiss FM. You could tell that the number of calls, I think that show that day was the biggest show we had, more calls. So the calls we got are people debunking, saying it's a lie. And actually, we are all not representing government nor anything. So there is nothing we can say rather than to just keep quiet and just listen to them. So I feel, I called Dapo that very day to inform him that let's be verifying some certain news before, we come on show to discuss about it. And yeah, one of the concern from my side, mainly, I have not been sending report on time, which I really apologize to that effect, because I have been up and running this couple of days. So basically, I think that's that for me in Abuja. Yahuza, I know Yahuza is here. He has been the one engaging with the guys in Taraba. So if you have anything to say, but from us, Akud, I don't think there is any major challenge apart from the ones I mentioned. Thank you.
Yeah, I think, Mukhtar, you've mentioned almost all our concerns, especially about the guests asking for stipend before they come to the station. Basically, sometimes I also have to go around, pick them, because the station is a bit far from the town. So I have to go around, pick them, and then give apologies. And it's okay.
All right, thank you, Yauza. So any other person, please make it a bit specific to COVID-19 and what people are saying or what your experience has been. Administrative concerns, of course, we will discuss that when we are over with this. But for now, we want NCDC to just hear directly from you how it has been discussing COVID-19. Yes, go ahead, sir.
My name is Marshall Johnson, Radio Nigeria from Bina FM, here in Yola, Adamawa State, the Sunshine State. Well, we tried this quarter that ended yesterday to make sure that we bring in guests of high repute who are newsmakers. But the challenge has always been that, owing to the fact that we had created awareness during, before, and after the elections, some feel it's going to be a political checkup. So some will develop cold feet at the dying minute, and some will like to postpone it, and some is indefinite. But I've tried it my own way. We have two guests every week so that if one fails, we'll pick up the other one. And it has actually been working, except for 2 occasions or so that we had to break it down. And then for COVID-19 compliance and questions that are frequently asked, we had the incident manager on one of the programs, Dr. Steve John, who actually explained so many unknown issues about COVID-19, especially the issue of community transmission and the testing, the percentages and all of this. And in fact, it became a fallback that respondents, we had to put it over to the news department for news for one of those days. So it has been a worthwhile situation, and the awareness, owing to the fact that Radio Nigeria has the widest coverage here, the awareness has been so great. I mean, they cry for um, uh, going down to the community, apart from radio, is what is a challenge here, because we have well over 87 languages, apart from Hausa and English. So yeah, I don't know how EIE will do that. But if it is the awareness for COVID-19, the protocols, the various acronyms, speaker after speaker or guest after guest have always been there to tell us, like the letters we had yesterday, forward. And if I'll be given opportunity, I'll explain that. It's part of the protocol for personal protection. So I think I have to drop it here.
All right, thank you, sir. Who else?
All right, Blunt is here. Hello, can you hear me?
Go ahead, Blondie. Yeah, I can hear you clearly.
Okay, good morning, everyone. My name is Talk Morgan, better known as Big Blunt from KTFM in Jos. I'm not sure we have much problems when it comes to getting of guests and them transporting themselves to the studio, but basically, the government side, those in authority are the ones we're having issues with. Mostly, they drag their feet before they come around. Maybe because they mostly don't have what to say. Because Nigerians have been waiting for palliatives. In Plateau State, not much palliatives have been given to citizens here. We hear of communities getting 5 measures of rice, an entire community. So it certainly will have people want to stay away from coming to talk on the media because they know certainly questions will be thrown at them and they don't have answers. But basically, the awareness has been fine. We've been dishing out. I caught you guys when someone was talking about one of the press statements you shared, Dapo, and how others were saying it's not true. I remember sharing with some medical personnel around, and they also said it's not true. So I was left in the middle, wondering what I should believe. But then, thank God for the internet, we had to do some verification, and we were able to scale through that. But it has been fine. It has been fine.
All right, thank you, Big Blunt. Others?
Hi, Dabo. Permit me to come in here. Hello?
All right, go ahead, Emeka. Yep.
Yes, permit me to come in. Perhaps we can continue with the chat box. I believe we've taken quite a good number of feedback. Okay, I can see Nasiru's hand is still up, but in the essence of time, we can continue in the chat box and all your feedback would be documented. Guests from the government has always been our challenge in Taraba as well. From Yahuza, Ahmed, okay? 2 participants raised their hands. So we have Nasiru. Let's take Nasiru and Matthew, then we'll quickly move ahead. Thank you so much.
All right, good morning, everyone. My name is Matthew Oladele. Thank you for coming up with this program, with this meeting. Well, for Niger, my AOP is online. I'm the partner with EIE in Niger. My AOP is the Maute Shade. We have been having it good in Niger, but most of the time we do have, just like Taraba and one other state, I've mentioned that the government representatives do drag their feet. Yeah, we do have such experience in Niger. Each time we want to bring maybe government, we even wrote to the government, to the Ministry of Health, to give them a 4 weeks in the first quarter, 4 weeks in the month of August, so that they can come online to speak to the people on all the activities of the EOC. But unfortunately, they refused to come until when in September they sent a representative, their PRO. Yes, they normally request for stipends for transport support at some point, so that because they believe that we've collected a huge sum amount of money to run the program, but they don't understand that we are doing almost a freeway service. We have been able to record a success story, because I remember in our third, fourth week, we were able to blow out we had our investigative journalists who visited the warehouses where they store the COVID-19 palliatives, and we noticed that some of those things are being moved out of the stores, and we have to come on air, call some of the logistics officers at the Central Committee on air. And a couple of weeks later, the following week, they set up because they have been saying that it is as a result of there is no list to verify who should be a beneficiary. But the following week, after our program, they actually set up the committee, and they started distributing at local government, and we have been following up. And one of our edition about 3 weeks ago, we were able to come up with the Chanchaga local government, who actually called in to air his own side of the distribution in the Chanchaga local government. So far, so good. We have been having it fine, but most times rough. Yes, females are not always calling in. If you have like 18 calls, maybe 2 or 3 females. If you have 10 calls, maybe 1 female most of the time. But it has been good. We have been able to educate the people more about COVID-19. And most of the time, they will say there is no COVID-19 patients in a particular local government. But at the end of the day, when we bring it on board to explain more better, and they accept, and the community are now aware and now taking up the challenge to prevent further spread of the community prevention of transmission of COVID-19. So that's the update from Niger. Thank you.
It seems we lost Matthew there.
I think it's done. It's done.
Okay. All right,
Yeah.
thank you. So I think we had one more person, then we'll move ahead. We had one more person with the hands up.
So he has lowered his hands. So my guess is maybe Matthew mentioned some of the things he was going to say. Yeah, so maybe we can just go ahead then.
All right, thank you very much. Thank you very much. Thank you very much, colleagues. We're moving ahead on the basis that most of our feedbacks will be very similar, and some colleagues have captured our thoughts as well. But I can see some coming in the chat box as well. Please let's keep that up. So we'll quickly move over to Dr. Lisu. Thank you so much, everyone. Dr. Lisu, please.
Okay, thank you very much. And we much appreciate the feedback. And I believe we'll be able to address them as we are doing our presentations. And notable among them includes how they getting topics for the talk show. And then also issue of, we would like to know, how do the guests get the content they come to discuss? I don't know. The guests themselves, on what criteria do you use to get them? I learned some government officials, of course, because of challenges with permission, and then sometimes it's not just permission when they are permitted, but they are afraid of the way media will ask questions and things they may not be able to answer, or what they will say that will put them in trouble. And if they are not trained to do that, then that is another challenge. It's one thing, if anybody is one of the things we do from our hand is ensure that one, we we assess the person. If the person has been somebody who has been appearing before, then we give the person talking points. And then if the person is not familiar with the topic that is being presented, so we kind of give the first person a brief of the development so that the person will be able to command some authority and then know what is really happening. And then the last thing is training or providing tips for this person how to engage either the media officials or whatever when the interview is ongoing, so that at least the person will have some confidence. And then again, it's also good to clarify where, I mean, do's and don'ts, and again, the red lines. Oh, we are not going beyond here. So it's also good to let them know what are their concerns, what are their, so that we can have them to come in and then be able to play their own part. So I think that's the major. I think we will see how part of our presentation will address some of those things. So now, first thing is to quickly talk about the public health response to this COVID-19, as in what Nigeria has been doing. First, we know that this is a global pandemic and it's not limited to Nigeria. So I started in China, it has moved around the whole world, and Nigeria is not exempted. Next slide, please. So, and it's good for us to know we've been hearing Nigeria Center for Disease Control. Yes, it was established in 2011, and then the act was passed and then signed into law in 2018. So Nigeria Center for Disease Control mandate is to prevent, detect, and control spread of communicable diseases in Nigeria. So essentially, it gathers information on diseases, priority diseases in the country, from every hospital, in every local government. And this is done through the existing disease surveillance officers in local government, who pass them on to the state, and the state collate and then send them to Nigeria Center for Disease Control. So that's about disease intelligence. But when there are outbreaks, states actually lead in the outbreak response. But NCDC provides support, guidance. Sometimes the support could be, most times technical, and then some resources too. But the states are in a position to respond perfectly to the outbreak because their localities, they understand their peculiarities. And the Nigerian constitutions put health on concurrent list. But when you have an outbreak that is more than what the state can handle, then NCDC may come in to take control of that. Or when you have outbreaks in many states of the federation, so you need a coordination that will make everything effective, because as people move from state to state, this disease continues to spread. So that's the essential thing, that the role of NCDC is good that we all understand this, that the states are directly in charge, but NCDC provides the supportive role and provide guidance and direction for this. Then to do the work perfectly, NCDC provide network of public health laboratories where they do confirmation of these tests. And then the states that have NCDC continue to accredit the labs and then to make sure that they operate within the approved standards. And then when it comes to research, to coordinate research, and that has to do with diseases of public health importance. And then also international health regulation that binds every country to comply with regulations when it comes to disease that can be spread across borders. So NCDC is the focal organization in Nigeria. Next slide. Next slide. Emeka, okay. Wow. Or should I share my own screen? Let me share my screen so that. Hello, can people hear me?
Yes.
Yes, we
Yes.
can.
We can hear you. We're following.
So I'm sharing my screen now, so I won't be saying next slide. So now this is the journey so far. How NCDC has managed outbreaks in the past since its creation. Ebola in 2014, that was a major task, the first one. Then polio reemergence, CSM outbreak 2017, and then 2018 we have Lassa fever outbreak. Although we've been having all these outbreaks every year, but when they become a major problem and everybody has to know and we all have to play our roles. So we also have monkeypox in 2017, COVID-19 in 2020. So COVID-19, basically, we all, of course, know about the symptoms of COVID-19, so I don't waste our time on this. And the incubation period is the time between when the virus enters the body and you first see the first symptoms. So it varies from person to person. On the average in Nigeria, it's about 6 days, 5 to 6 days. And that's why recently, when they say people are traveling to Nigeria, that they ask them to do the test day 7. Most of them manifest before them, but you still see people who manifest on the 11, 12, maximum is 14 days. Of course, disease spread from person to person by droplets and from place to place as people carry the virus move around. And then signs and symptoms also include recently the additions are loss of taste, loss of smell, and general body weakness. It can present like any ailment, malaria. So that's why people mistake it for, they say, no, it's malaria. Sometimes it can exist with malaria. The strategic objective for the response, and the main goal is to detect this disease early, and then when detect it early through signs and symptoms from those who have it, especially people who made a case definition, people who have traveled to areas where they have this disease or coming from area where there is transmission. And of course, this confirmation has to be done through the laboratory. And where we do this through screening at the point of entries, where people come into the country. And then, of course, I mentioned the laboratory, and that also requires training and retraining of human resource for us to be able to do this properly. Then when the cases are detected, the next thing is they need to be managed because we still have mortality from the disease, even though it's low. And then the mortality is usually seen in people who are elderly and then people who have other conditions like hypertension, diabetes. So irrespective of age. So that means we need to have a good way of managing them so that we have a lower mortality from this. That requires us to identify treatment centers in each state and equip them. And then sufficient and trained human resources will be able to manage these treatment centers. Then supplies to medical countermeasures, supplies that they need, PPEs, drugs, and they need to manage the cases. Coordination and communication with Nigerians is very key because the way the disease is spread, it is spread due to our practices, our individual actions. So required to stop this transmission. And that is why we have to modify our lifestyle, our activities, take new safety precautions or measures like wearing of implement the coordination of the response. It was true or is true National Multi-Sectoral Emergency Operations Center they have in NCDC. It has various pillars, the laboratory pillar, the surveillance pillar where they do the detection, and then the case management pillar, and then also communication pillar. We also have logistics and then infection prevention and control pillar that ensure that the transmission of the disease within the facility and community prevented. Then leadership is very key because this is the kind of outbreak that requires a multi-ministerial cooperation. interministerial cooperation, I mean, because disease comes through the airport to the country. So you need Ministry of Aviation cooperation to be able to review their procedures in the airport to ensure that we don't encourage transmission. Even if you have to shut down the airport, so you will only need the understanding and cooperation approval of Ministry of Aviation. Also, education sector. To shut down schools, you need a Minister of Education to cooperate, and so on and so forth, humanitarian sector and so on. So that is why at the presidential level, a presidential task force has to be established to facilitate coordination of this interministerial collaboration, and then mobilization of resources that are required to do this, and also other multinational stakeholders, the private sector stakeholders. So that's what presidential task force was able to do, to make sure that all the effort resources are coordinated. So it's also good for us to understand where we are with regards to this outbreak. Although this is not the latest data, because today is 22nd, but this slide is just, what is important on this slide is to show us that we still have 72% of confirmed cases that we don't know their sources. We can't trace where they get them from. That is a strong indication of community transmission. So our hope is over time, this will reduce, and then the yellow portion, which is people that we can trace their sources, that increases. It is when you can trace the sources of the disease that you can now know how to perfectly control it. So, and the sad story is we have been over 70% for the past 2-3 months, and it doesn't look as if we are progressing. The only way we can get out of this is when everybody begins to use face masks, adopt the measure, and this disease come down drastically. Then the few cases we can trace their sources and then be able to also, sorry, it's good to
Hello, sir, we can't hear you.
that the
Okay. Hello, Dr. Diso. Okay, so I think we lost.
Okay. I don't know what happened. I just got automatically muted.
Oh,
Okay.
I don't know what happened as well.
So
You have to share your screen, sir.
Oh, I lost my screen. Oh, that means I lost the network then.
Yes.
Oh, sorry, I didn't know that. So how many minutes ago so that I will know?
So you're talking about how it has been 70% for about 3 months. Then at that point we stop hearing you.
Okay.
Yes.
Okay. So I said 70% for about 3 months, and that means we are in community transmission. The only way to get out of this is for everybody to comply with those measures, wearing face masks, social distancing, so that the virus can die within those who have it. It doesn't have opportunity to spread again. And the few people that we can now get, we can manage their sources and then get rid of it. But the 2% that you see here is for those who travel into the country. I am so happy that that number has not increased. It shows that Nigeria is now controlling those who bring it into the country. You know, the challenge was initially, before closure of our airport, before the lockdown, we were telling people come into Nigeria to self-isolate because they refused to self-isolate. That is why the cases started spreading in the country. And then we learn from that. That's why when we want to reopen our airport, we now make it mandatory that they must do the test before they even board the plane to first show that they don't even have it. But we still know that 96 hours before they board, right? That's when we want them to do the test. But between the time they are boarding and before they get to Nigeria, they could be exposed again. And they could carry the virus in the last 48 hours that we may not know. So that's why we still say 7 days after you come to Nigeria, you must do the test, right? So that we will now know that if you are negative, then we know that you are free of the virus. I think that is why the proportion of the confirmed cases that are travelers is still very low. Or could it be because we have a large number of community transmission, but we are all watching to see how we progress. So this is the trend of the disease, the epic cough now per week. And you can see that it's coming down. They were not so happy again because testing, when you compare to number of tests we do per day, the testing rate has dropped significantly. People are not coming out for testing. Is it because they are tired? Is it because they think COVID-19 is gone? Or is it because they don't have access to testing? They don't know where to do this testing? Those are issues that we just have to all consider. And that's why you are all in this together. We're all in this to find out this and educate and convince people to take the right measure. Then when you look at gender distribution, age gender, I think at gender distribution, you can see that the people of maybe less than 20 are least affected. Is it that because they are not exposed, because we shut down at schools, most of them are at home? The age group most affected, 31 to 40 years. These are people that go out to fend for families. And then all age groups are affected. So we can see that here. And then we can also see the deaths in red, and both male and female are affected, but more males are affected than females. So why? Those are questions that we all need to answer. Why is it that more males get this disease than more females? So that if we understand this, we know how to tailor our communication for addressing this. Then children are dying too. So if you look at the case fertility rate, that is the proportion of people among the people that have it, how many of them die? So you see that less than 10 years is 0.8%, 11 to 20, 1.6%. But the key thing is children also die. Now that we have reopened schools, what is the chance? That we had last week that a school in Lagos reported over 180 cases, about 181 cases as at that time, out of about 400. So which means this thing can really spread among children if necessary precautions are not taken. And this is the epic cough, the cough for children between less than 20 years, for us to understand how this disease spread, especially with reopening of schools. So we continue to monitor this trend to be able to proactively prevent and then respond promptly in case that we have cases. And this requires multi-sectoral collaboration. It is also important that we understand how far we have gone so far. The first chart up shows our trend, the epic curve from February till October. But the approaches government has adopted, when it first started, it was more of multi-sectoral approach led by health sector. That was NCDC, Federal Ministry of Health, leading the response. But when it got to level where we need other ministries, aviation, education, and so on, then all of government approach was adopted, and that was led by PTF. And then when we enter full community transmission, then whole of society approach was adopted. That includes all segments of the society, all levels of government, community, private sector, everybody, NGOs, civil society organization. This is meant to be community-led, because to tackle community transmission, you require community approach, and you need the community to lead in the process. That has been the campaign. But it seems they still not understand it, because people see this as national response. Sorry, they see it as federal response. National response means all of us. Everybody has roles to play. Many of the states, but like everything is NCDC, no. It is not NCDC. Local government has role to play. States have role to play. NCDC has role to play. Even sectors outside health also have roles to play. Then lessons we've learned from this, because of early preparedness, the moment the first outbreak was reported in China, NCDC set up a multi-sectoral preparedness group that started working with all the pillars I mentioned earlier. And that was when we started planning to set up laboratories to be able to confirm it. And we prioritize where these laboratories are and our interventions based on states we think people can come into Nigeria, like Lagos, Kano, Port Harcourt, and so on. And then training by WHO, African CDC, and then training of personnel for risk communication. And then we launched the Take Responsibility campaign late in March, because essence is for people to understand that it is actually what we do that will determine how we can overcome this disease. So we all need to be responsible at individual level, at family level, community level, policy making level, private sector. Everybody has a role to play in this. And that has actually helped to some extent, but it seems we are losing out because people are getting tired. Then political leadership has been very key, presidential task force, but there are still issues with this. Probably bottom-up approach was not properly adopted when it comes to implementation of some of the strategies. And then maybe that's the lessons we have to learn. And then plan flexibility. As things evolve, we continue to adapt. Our communication strategies continue to also change too. Use of virtual platforms has also helped us, like what we're doing now. And then we continue to share regional experience. Meeting Africa CDC, we still had a meeting yesterday where countries were invited to do presentation, to share experience. Every month, 2 countries present what is happening and other people learn from it. Even West African Health Organization, they do that. Then now, we're in the stage where we are promoting sector ownership to promote sustainability. Now, like education sector, they develop their guidelines. We support them, provide technical support again for them beyond development of guidelines so that they can implement what they are doing. They will continue to provide key messages regularly to update these people, these sectors. And then to also, we try to get feedback to track what they are doing, how they are complying with the guideline, where they need further help. But we're still having challenges because many people still do not understand what full roles they need to play in this regard. Major problem we have is pre-existing mistrust for government in this, and that has really affected almost everything. So these are the major interventions that you can see: communication campaign, travel restriction, lockdown. Lockdown is now travel resumption. Thank you, and that is for the update on the COVID-19 response so far. Do we want to take questions here before I move to risk communication, or I present the communication strategy before? Thank you. Hello, Emeka.
Yes, Dr. Disu, I'm here. Thank you so much for that elaborate presentation. For now, we've not seen any hands up, but Dr. Disu is also taking this the next presentation. So we can ask questions now if we have any, or we could ask in the chat box. Then when he's done with the second presentation, which is quite similar and related, we could take all the questions. Okay, I can see one hand up. Chimeziano Yago, you have the floor. Thanks.
No, Emeka, just to point out that there is a question on the chat box from Jibril Abubakar Sadiq.
Okay.
Okay, can you read the question out? Chimeze.
Yeah, I think Jibril is talking about that testing has gone down because some states doesn't have testing centers, and also states government has stopped encouraging citizens for testing, especially if someone experienced symptoms. So I don't know if you want to clarify this, Dr. Disu.
Okay, thank you, Chimeze. maybe because Chimeze is also one of the facilitators for this meeting, and is also a member of this communication
It's
team.
actually the case. What exactly is happening?
Chimeze is in the field. He's in Imo
Hello,
State.
Dr. Disu. Sorry.
Yes.
So I don't know if you want to clarify that. Is that actually this, or
That's
what exactly is happening?
That's what I'm trying to do. I want you to talk, since you're on the field now, working with Imo State. What are the issues? So it's better somebody in the field tell us what exactly is happening, since it has to do with the state. Can you share your thoughts here, Chimeze, for 2 minutes?
Okay, so maybe to from the Imo State perspective, what is happening here is actually on the contrary to the comment that was made here. Imo State has activated sample collection sites in all the 27 local government areas in the state. And one thing that the state is pushing forward is community testing and encouraging everyone to come out for tests. And the state is actually using is using like a three-pronged approach to testing. One is the decentralization of sample collection in all the LGAs. Secondly is to use a wow truck. There's a wow truck that they use to go to different LGAs to create awareness and have people come out, apart from going to the sample collection sites. And thirdly is that the state is doing some targeted tests in big hospitals and places where we have a lot of people converging. So they go there and encourage people to come out and get tested. So that is what we've seen in the... Hello, can everyone hear me?
Yes, go ahead.
Yeah, so that is what we are seeing in Imo State. But recently, from the happenings around the country, even though we are still collecting samples in different LGAs, the state laboratory capacity is really not up to the number of samples that we are collecting. In a day, the state is collecting over 200 and something samples, and the state can only test up to 60 samples in a day. So there is need for us to transport the remaining samples to the laboratory in Abuja. But what we've seen is, because of the protests and the blockades and everything around the country, we've had some challenges in sending samples to Abuja, which has made us to start storing samples and waiting till when we'll open the our airspace and the roads before we send the samples to Abuja. We are also testing the ones we can test here, but every day we keep on getting more and more samples. So that's actually the challenge that we are facing over here. Over.
Okay, thank you, Chimeze. That may be the peculiar experience in Imo State. It may not be the same in other states. And I know that this question that this fellow asked, we have a meeting with the DG is having a meeting with the state epidemiologist today, and I'm going to raise this so that what's happening, that we are getting feedback from the community that state themselves are the ones that are not encouraging people to come out for testing, so that we can hear out their response. I think the other people who are raising hands, can you please go ahead and raise and ask your question quickly so that we move? Hello?
Jibril, do you have something else to say? Your hand is
thought I
raised.
saw two people.
Are you done?
Hello.
Hello?
Yes, this is Marshall Johnson from Yola. I appreciate the presentation, and the information gathered is very cost effective, and it's going to actually help us see what we'll do. But my worry is that in and around the Northeast, I have gone a couple of states to look at. We've actually not seen billboards with pictorial descriptions which carry a lot of message, aside from the radio and using musicians to do the jingles. I think we should have thought of putting up billboards with pictures on face mask, how to wear it, how to wash your hands, how to use the sanitizer, how to do social distancing. I think this aspect is actually missing here. I wouldn't know if it's the same the whole country. So I don't know if Dr. Yusuf will respond to this.
Okay, thank you. With regards to billboards, it varies from state to state. What they would like to project, and then who is they are partnering with, and sometimes some of these things come with cost. Some of them are under the purview of the state, but it depends on the state. I don't know why you don't have it there. And even me, generally, I've not been even seeing billboards around. Usually, when you want to send the information that is maybe when you say step by step, billboard might not be the best thing, but something that you want to elaborate the picture, put in the minds of people that this is necessary. We need to do this, so that when they think of it, it comes to mind. And then there should be other arrangement whereby they will be educated. That is the sense of community engagement from local government, CSOs, community-based organizations, and then working to make sure that they educate the people on how to do this. Sometimes your program, somebody you can bring in resource persons to come and explain what people need to do, how they need to do it. Then there are posters too. They may not necessarily be billboards, but they can paste around that shows 10 steps of hand hygiene, how to perform hand hygiene, and what you need to do to do so, how to wear face mask. We also, yes, we acknowledge that there are jingles, there are animations, they are in circulation, but we may need more than that. But if they can do billboard, that is fine. I think it depends on the state. We may also raise it with the health educators from that region to see what they can do with that. Thank you. Okay. So,
Dr. D'Souza.
Yes.
So I have a question to ask, sir.
Because we still have a lot to cover. Maybe some of those questions might be answered by subsequent presentations. But ask this one.
Okay, so my question was just going to be that you've shown us that there are low testing being conducted per week. Now, is that because states are not putting as much effort as they were when it was high? And can the low test conducted be the reason why we're having low numbers being confirmed?
Yes, so second question, low test can be the reason we're having low numbers. Because you only have to do tests to know people who have it. Then why are people not coming out? Is it that the state is limiting them from coming out? No, every state has laboratory now. And then they are supplied with necessary reagents they need to do this. The only thing that may require is logistics for collecting the samples, because to go to rural areas, you need personnel who will collect the sample and then transportation of the sample. So that might be a challenge for the states. I'm not sure that should be what should discourage them from doing that. Then people themselves, a lot of a situation whereby people don't even believe this COVID-19 is real. They say it's calm. They even say it's malaria. Or when they even think it's COVID-19, they believe they have treatment for it, that they can treat it on their own and with anti-malaria. So they will wonder, why should they go and waste their time for tests? And then we also have issues with test results too, not being released by state on time. So if somebody has submitted a sample, 3 weeks, 2 weeks, he has not gotten results, and then his neighbor wants to do, they will tell him that, don't bother yourself. Even me, I'm not collected. Just go and take anti-malaria and forget about those people. So that's why we have to improve on our turnaround time. And the only way we can improve is by getting feedback like this, and we tell people who are in charge of these processes for them to also adjust. So as we are talking to the public, we too are also talking to people in charge of various processes that need to make things happen. So thank you very much. So let me move to the next one swiftly. It's about risk communication and community engagement. And what we do in risk communication and community engagement is to provide information timely for those who need it so that they can take informed decision. And then it is not only the NCDC or the state government that should provide this information. It's actually exchange of information, which may be between officials and the members of the public that need this information, or between experts and members of the public. That is why you bring in guests, resource persons to your program to come and talk. They don't have to necessarily be state epidemiologists or officials of the Ministry of Health. Or sometimes it will be from opinion leaders, like religious leaders. You bring them for them to come and talk, the ones that have understanding. Because sometimes the issue is not the message, but the messenger who is talking. Many times people don't believe government people, they believe they are lying. They believe, oh, they want to embezzle money. They don't want COVID-19 to end in the country. But when they see their traditional leader, religious leader talking, then they are likely going to believe them. So this communication is a major intervention that we require to drive the behavioral change. Our strategic direction, our goal is to mobilize all stakeholders at all levels to promote Take Responsibility campaign, uptake and utilization of key messages by individual families and communities. I've talked about Take Responsibility, that we all need to be in that mindset, that our actions determine how successful we are in this. So everybody has role to play. And then the messages we need to help us, we need to seek them, get them, access them, and utilize them properly. And that is the only way to go. And our objective is increase stakeholders' engagement with defined rules and responsibility. This is the time every stakeholder needs to be on board and be on the same page, so that we don't duplicate resources. We don't duplicate effort, and we can optimize our resources. More importantly, we don't send out conflicting messages. Different government agencies may send out messages that conflict and that will undermine the trust. Then our objective is to also strengthen coordination capacity to promote ownership at subnational level for the Take Responsibility campaign. We know that at the subnational level, they need to be more coordinated. They need capacity to build capacity even at the grassroots level for people to be able to own this, promote this Take Responsibility campaign. And the last one is for us to develop and roll out strategy for reaching at-risk population, that is the population that can easily get this disease, the vulnerable population, people who suffer severe illness from the disease, and then population with special needs, like people living with disabilities, and then general population, which is what we're doing. And that part of the strategy is where you come in, public communication, using the media to interact with the public. And then in order to make that more efficient or effective, that's why we are having this dialogue. Our core operations for risk communication pillar are development and sharing of the guidelines. RCC means risk communication and community engagement, and the standard operative procedure for the response. That's the primary responsibility at NCDC level. We are not only developing guidelines for NCDC for risk communication, we're also supporting sectors to develop their guidelines that they can hold. We monitor the outbreak trend and pattern, and then the risk assessment report that is produced, as well as the perception of the public, to be able to know where to focus on, how to tailor our messages, and what message to send out, when to stop talking, when to continue, when to intensify. And then conduct risk communication need assessment. When we know where the gaps are, we monitor the trend. Then we monitor the trend, we know the perception. Then we want to do communication need assessment. Do we have what it takes to meet the communication requirements with regards to infrastructures, capacity, resources, and then time, and so on? Then we now adopt appropriate communication strategy. It varies from outbreak to outbreak, even in the same outbreak from time to time, based on several factors. Then we collect data through our online social media, traditional media, from the community, and then from our call centers, and then to analyze them and transform them to scientific information. Transform this information into consistent health communication. The key messages we roll out, that's how we generate them. but we also ensure that the messaging across MDAs and all stakeholders are consistent with the national approach. Whatever we're doing, it has to be consistent. Otherwise, we will lose the trust. The NCDC does not really have structures across the country, but we leverage on the resources, the structures, and mandate of the relevant MDAs. Like for the community engagement, we leverage on National Orientation Agency and the National Primary Care Development Agency that are there. We produce our content, we give to them, we build their capacity, and we continue to give them key messages and then monitor what they do, get feedback from them. So, like I said, we build capacity of these MDAs, the state risk communication team, and other stakeholders, security personnel, media. We continue to do that so that they will be able to know what their expectations are, how to do their job. And then we coordinate and align the RCC activities of all stakeholders in order to optimize the initiatives that everybody has, efforts, available resources from all sectors, so that we don't want conflict. We make sure that we have a National Risk Communication Technical Working Group that bring all this together. Even at PTF, when PTF was created, they have a risk communication pillar there that is supervised by Ministry of Information. We are an integral part of that. We make sure that all stakeholders work together with one voice. And then that is within, in the same level that's at each level of government and across level of government. What we're saying should not be different from what Lagos is saying. They should not contradict each other. I've talked about how we collect and analyze data weekly to inform our messaging and also manage misinformation. Beyond this, we also provide feedback into the operations of the EOC, feedback to case management, feedback to surveillance, feedback to data, to laboratory, in order to shape their policies and strategies. This chart is just showing us our messaging focus. For you in the media, this may interest you. First is, if you look at the triangle, you see facts, task. Initially, when the outbreak started, when we don't have much information, the public do not know basic things about it, about the cause, symptoms, transmission, how fatal it is, treatment, prevention. So what we need to do is to keep people informed of this. And then that's the major thing we're doing. And the task, what they need to do to be able to keep themselves protected. And then, of course, comes their challenges. So we consider the clarity, complexity in framing those messages. Then as we move on, especially when we enter lockdown, a lot of misinformation here and there. And feelings, emotions were running high. So, and we have to look at the emotions. Do we motivate them? The messaging is framed in order to motivate them to adopt this change. Some of the things that will affect their feelings with ability. When somebody does not have confidence, they will have the skills to implement that, fear will come in. When attitude too, if they believe that this thing will not work, no, government, this is, or when they are positive about it, it determines what they do. Their perception, risk perception. Do they perceive the risk is high or low, is real? It also matters. What they attribute as the cause of the problem. Do they feel it's government error? Do they feel it's a natural thing? Do they feel it's individual responsibility? That's why they are having it. Then the culture also affects how we express our emotion. And then the need at that point in time will determine the kind of feelings we have. So our messaging is, we adjust our messages based on the feelings. Another consideration is issues they may have when they are motivated to they know what to do, they are motivated to do it, but there are barriers. For instance, they want to do tests, they don't know where to do the test. They have signs and symptoms, they don't know. Or they even know where to do the test. It's not clear what to do when they want to do the test. The protocol is not clear. Or there is no transparency at the state level. Maybe they collect your sample. In some places they say you pay, some places it's not, you don't pay. Oh, maybe it's not clear whether it's in private lab you pay or so. So when people are not transparent, those are issues that can affect how they uptake the services or the relationship with the people they are having interaction with, or sometimes cost, or the feedback, inequity, and so on. So we listen to all this, we get all this feedback and begin to also address them. Some of them we escalate to the state concern when we hear them. And the last factor is the context. We have various types of context: political, environment, social, cultural. This may vary from state to state, from region to region. Even the timing may affect how we craft our messages. The technology, then the economic situation, the ethics, the legal situation will determine how we do all this. So those are things that we consider in crafting our messages to drive behavioral change. And then the context, of course, affect everything. The context affect the feelings, can affect the even what people know, how they interpret their messages, and then the issues, challenges, and how those challenges are being resolved quickly. So it's good to just for us to quickly know that our charts, from our dashboard, we do media monitoring weekly. And you can see from June down to October, the green part of the chart, positive sentiment from the media. We're looking at how the media has been reporting. 48% of them initially were positive sentiment. Then when it comes towards July, August, it increased to 55% if you look at the left side. Then as at October 25th of September, 67%. Now, October, we are getting 65%. But the thing is, you can see the trend that it has been increasing. So we really commend the media for this, and we want to encourage it because we've been having a lot of interaction with the media. We have a platform where we engage with the media. Emeka will mention that later. That way they learn more about what we do and they understand us. They can verify information before they go. So we want to encourage this. That is why we appreciate this dialogue we are having now. We also do analysis of our call from Connect Center. And then, what I just want to show here, of course, we have drop calls, we have a general inquiry, OAPs call, and then call not related to NCDC. Maybe let me just explain so that we understand this and we're able to also inform the public. Drop calls account for 40% of the cases, calls in June. Drop calls are calls that, because the centers, the lines were overloaded. People were calling from right, left, and center. So they can't pick all the calls, but the system picks it. Right. And later we analyze this. But OAPs call, 28% as of that month. Those calls are people who just call and say, you are stupid. It's not about COVID-19. I just want to tell you are stupid. Some people will say God will punish you. Some people will say they will hear a female voice on the line. They will say, oh, I want to sleep with you. Some people will, all manners of things that people say. And those are the ones blocking the real people that need this call, that want to find out about where to do the test. So we need to educate Nigerians. If you don't really need to make the call, don't make the call. Let people that really need it. Now, when you see a drop call, later it dropped to 37% in August. By September, it dropped to 30% and it stayed 30%. So it means the service is also improving. We are expanding our lines, but you can see their host call has increased to 37% in October. Maybe because people are hungry, but we continue to educate people about that. Then we have a rumor log. All the misinformation that we are getting, we also classify them, analyze them for their impact, and then prioritize how to respond to them. So how to respond to them. So you can see this and then the impact out. What I just want to emphasize is how they can cause risky behavior. How they can cause risky behavior. And then you see risky behavior, you see speculation, fact, misconception. Maybe another session we'll be able to explain this. Then this is also dashboard, that opinion poll we conduct every week. And then you can see people recall whether people are getting advertising, publicity. It has been dropping if you look at the uppermost part on the left. And then even the messengers are getting tired. And then, so we need to continue to encourage ourselves to talk about it until COVID-19 is defeated globally. The issue of trust too. Trust quotients has also been, they believe in federal government effort. Even when you have this slide, if you look at it, you'll be able to understand. It looks as if misinformation is coming down gradually. And then when you look at the trend, and then also there are also messages on education, preventive measures, when you reopen school, what measure people prefer most, what is more difficult, is it hand hygiene or physical distancing? We'll see there. But these slides sometimes in the past show that most of the sources of misinformation, if you look at this, where we hear that corona infects only rich people, you see 10% of them say television, and although most people say from the community, their neighbors. But whether herbal medication can cure, and then you also see some percentage, 17% say television, 15% say radio, and could it be the people, the anchors that do not understand to encourage them to and stop the correct the guest when the guest are not saying the right thing, or guide the guest or ask the guest the right questions. So I think the role of media is we want you to sensitize the relevant stakeholders and the public to understand the outbreak and what measures are adopted to control it. And this is then we want to also want media to promote adoption of safety measures by all stakeholders and public as prescribed by PTF and NCDC. Then embrace factual reporting through verification of information. That's why we are having this interaction. Now we will give you links and then people you can call to verify information, and also joint platforms where you can have regular interaction in case you are not part of that platform. Facilitate public participation and remind the stakeholders to disseminate key messages to their staff, members, family, and the community. So we are doing that already, but you also need to, like, education stakeholders, remind them, what are they telling their teachers? What are they telling parents, PTAs, and so on? The transport sector, what are they telling drivers? The road safety, what is their role? And even their own families to continue to build capacity of the media on epidemic management. Thank you very much.
Okay, thank you so much. Dr.
I am true.
Yes, thank you so much, Dr. Dusu. Unfortunately, time is not on our side, and yes, we might quickly have to run through. I believe we can take questions in the chat box, please. Time is not on our side. We would want to immediately take Halilu from USCDC, quickly take us on to the next presentation. He's in briefly, so we might just want to take his presentation, then come back to the second presentation, which is on an NCDC communication channels. Very, very wonderful presentation from Dr. Dusu. Thank you so much. We are seeing thanks on the chat box. And please leave your comments or questions on the chat box. Please, they'll be attended to. If Halilu Usman is online, please, we would like to take your presentation now, sir. Thank you.
Good morning, everyone.
All right. Thank you so much.
I hope you can hear me.
Yes. Yes, we can.
Great. So once again, a very good morning to you. I believe it's been a wonderful conversation already. I have been introduced already by Emeka, but just to say, my name is Halilu Usman, and I am the country communications lead for the U.S. Centers for Disease Control and Prevention, one of the United States agencies that is providing support to the government of Nigeria through NCDC, as well as the Presidential Task Force, as it continues to respond to the ongoing COVID-19 pandemic. The focus of my presentation is more or less around, framing messages for the media based on the outbreak response priorities. what I will be doing essentially is to be taking us through a couple of proposed frames that we believe, if adopted and utilized, will help to increase information around COVID-19, as well as ginger people to take the necessary action that is required for them to first, protect themselves, and then secondly, prevent spread in our communities. Next slides, please. So, and I'm sure this must have come up already in the course of our discussion this morning. Basically, when we respond to disease threats, what we try to do is to detect threats as early as possible. In the case of COVID-19, I think the very first case in Nigeria was detected fairly quickly and managed reasonably well. I think where we had a challenge was the few more cases that came in, especially as Nigerians abroad began to return home, and then our assumption that people will adhere to the protocols that were recommended did not see the light of day, as a lot of people actually did not adhere to that protocol. And we found ourselves in a community transmission stage as, very early in the course of the outbreak. So also, one of the priorities is to respond rapidly and effectively, as well as to prevent additional avoidable outbreaks. So those are the response priorities, and our frames are proposed to address some of these response priorities. Next slide, please. So this is the biggest frame that we are proposing, which is basically talking about, individuals taking personal responsibility for collective good. So as we continue to respond to the COVID-19 pandemic, it is essential that what we hear from programs, on television and radio, opinion pieces, are tilted towards, highlighting the fact that individuals at homes, in workplaces, in our societies and communities need to take very personal responsibility, if we are all to come out of this in one piece. So that's about the biggest frame. And then we have a couple of subframes that I will be taking us through quickly. My understanding is this is more about what you take out of this and what comes out from you in terms of, your observations, your comments, and all of that. Let's go back to the presentation, please. Can we go back to the presentation, or can I just go ahead and share my screen?
You can share your screen, sir. I've made you co-host, so you can just do it directly. So.
Okay.
Thank you.
You're welcome.
Yes, please. My network seems to be fluctuating.
Okay, no problem. Not that there's any guarantee here, though, but at least we have alternatives. So, and I believe can you see my screen right now?
Yes, we can.
Oh, great. So this is where I was talking about the biggest frame. And here comes the very first subframe is about, focusing on the fact that COVID-19 is here and it's real. So this may sound a bit intuitive for those of you who are already doing this a lot, but the fact remains that some people out there still need to hear from you that COVID-19 is very much around with us, and it's real. We still have a pocket of individuals and groups who still do not believe that COVID-19 is real, and for that reason, they really don't take the necessary action to protect themselves or to even prevent spread when it occurs. So simplistic as this may sound, it is important for our programs and our presenters, our producers to continue to focus on the message that COVID-19 is very much here with us. And even though cases have fluctuated, but they are actually now on the rise, in our communities. And many more are likely to be discovered as we continue to search for cases actively. So people need to hear this and actually understand that this is our reality, and this current reality is likely to be around for a while. The more they hear this coming from you, the more they take it seriously. While emphasizing the fact that COVID-19 is here and it's real, we also believe that if we frame our messages from a global perspective, it will help because we all know that at some point, Nigeria was really not experiencing coronavirus, and then it came to our shores, and then, we tried to contain it, and that didn't happen. We now are trying to mitigate the spread as much as possible. And so, emphasizing the fact that this is a global thing, it's a global phenomenon that has actually devastated other nations, what we will call even stronger nations, either economically or politically, having challenges, addressing it will, coming from you, will actually prove to Nigerians that we are not alone. And as bad as things may look like, we are succeeding in some places, and with their additional cooperation, we would be able to, come out of this in one piece. So we have also seen that the countries that have fared better, are those who have taken proactive steps to contain it or to mitigate its spread. We believe hearing from you some of this key information about this not being only a Nigerian thing, not being a rich person's thing, not being, only for people who travel, will further reinforce the messages that are going out from the intervening agencies. So one more frame that we are proposing is emphasizing to the public, to your listeners or your viewers, that listening to experts' guidance is key to survival. You all know that health experts have made a couple of, recommendations right from the early stage of this pandemic, recommendations that include, physical distancing, wearing of face masks, regular washing of hands, and all of that. So the more we, emphasize on these messages and continue to call on the public, your listeners, your viewers, to listen to experts, the more chances we have of, people taking those proactive measures to protect themselves. The thing is, as people in the media, your reach, your influence can not be overemphasized. So in as much as NCDC is working around the clock to ensure these messages are out there, what comes out from your opinion pieces, from your programs, from your, editorials matters a lot. Because while the public do listen to NCDC, the fact that you reinforces those messages will ensure that the public adhere to some of those recommendations. Again, the COVID-19 response in Nigeria has moved from one stage to another, starting from, NCDC solely providing support and guidance, moving to the Ministry of Health, and then having additional MDAs coming in to play their roles, and of course, to where we are now, what is called a stage of, a whole of society approach, where the government, the media, community and religious leaders, civil society organizations, everybody has, one role or the other to play. If that is the case, then it is important that we continue to frame our messages in such a way that members of the public will not only be holding government to account, but will also be holding, each other to account, meaning that the earlier bigger frame of, individual action, ensuring collective solution is key in terms of, addressing COVID-19. So while we talk about, the numbers, and this is fairly represented in all of the Nigerian media. I mean, every morning we hear about the number of people who are infected. If it goes high, that is reflected. If it goes low, it's reflected. We hear about the cases all of the time on the media. But one frame that we need to hear more from the media is the frames that appeals to the heart, in addition to logic and facts. Yes, people are interested in those numbers. People are interested in knowing what they need to do to protect themselves or to prevent the spread. But the truth of the matter is that people will pay attention if we appeal to their heart. If our stories, talk about how people are personally affected, how your inaction will lead to your innocent child or your mother or an elderly person in your family getting affected. When we hear the story of survivors, how they have struggled to overcome COVID-19, or when we hear how, vulnerable people have actually lost their lives, when we hear the impact of the life lost, how families have become, orphaned and all of that. So all of those things that actually appeals to our emotion are just as important as the numbers that we dish out every day. So if we can begin to focus on personal stories, individual stories, and how it is emotionally connected to families, that will certainly lead to a change of, the situation that we are seeing. And this will have to come from the media, because no single organization has the reach and the capacity to make sure this is in the front burners than the media. So quickly, there's also the need for connecting individual responsibility with collective action. Framing COVID-19 as a disease that has both individual and collective threat will give us our best chance at getting people to change their risky behavior during the crisis. We all know that if a particular family, a particular office, or an organization, everyone is doing the right thing, and we have this one single individual who insists on not wearing the face masks, on not, the physical distance, not adhering to physical distance or regular hand hygiene, that single individual could undo all of the things that those collectives are actually doing, which means that for us to be safe, each and every individual has to take the necessary action to protect himself, thereby protecting the collective. So again, there is need for us to frame some of our messages in line with providing hope instead of hopelessness. It is true that COVID-19 is a devastating disease. I mean, in the wrong person, we have seen how devastating that could be. And in a very good number of cases in Nigeria alone, we've had over 1,000 deaths so far. Around the world, we've had hundreds of thousands of deaths to date, which means that, and this thing keeps, there are realities, but the truth remains that in as much as we continue to talk about this, there is need for us to also talk about, the fact that, well, for a majority of the people who contract the virus, they will simply have a low to moderate form of it. A lot of people who are already not having some, underlying condition are likely to, even if infected, come out of it alive. We need to focus on the fact that science is making tremendous program around, therapeutics, around treatment, and even around vaccine. All of this tend to give hope. We really need to give hope to the people, because the fact that there is hope will lead to, reduction of stigma and discrimination that we have seen in the early period of this intervention, where people are actually stigmatized and discriminated and all of that. So while we want to actually continue to talk about the numbers, we want to continue to talk about the threats, we also want to reflect, the fact that all hope is not lost, as we are making tremendous progress to, provide a lasting solution to the pandemic. It's important to also reflect the fact that ignoring risk puts self and loved ones in harm's way. This is somehow, connected to, appealing to people's emotions. So it's, again, bringing it back home. You may be well, healthy, and think that there's absolutely nothing that will happen to you. But the truth remains that unless you take proactive action to protect yourself, you are likely going to, infect others who are vulnerable, and they may not be as lucky as you are. I think because you all will have the opportunity of going through the slides, this is just about a frame that talks about vigilance instead of panic. You will have the time to actually go through it and all of that. So just to round up, I'm rounding up with this frame that is connecting us to the first one, which talks about taking responsibility and recognizing that we are all in this together. And if we are all in this together, we actually can stop this together. So we need to hear this more coming from your programs, your presentations, your editorials. That way, the work that the NCDC is doing, the work that the PTF is doing will be further amplified, and the public will have a lot more confidence in the response than they currently do. Thank you for the opportunity to share these frames with you, and I'm open to answer your questions or hear your comments and observations. Over.
Thank you so much, Halilu, for that excellent presentation. I believe it was very, very valuable for participants. We still look forward to questions or comments on the chat box, and we are actually running out of time, but I believe we are still on course. The next, I can see, okay, thanks. This is a nice one. This is from Malted Shade. Okay, no hands are up yet. Well, please, we'll just go over to the next presentation. It will be very, very brief. Then we can take all questions and comments. Dabo, are we together?
Yes, Emeka, we lost you at some point. I was trying to say that.
All right, thank you so much. I was lost at some point. Jibril Abubakar says, thank you, Mr. Halilu, for the wonderful presentation. So I'll just quickly share my screen. Apologies for the network frustration. I can't even see the previous chats on the chat box, but I'll try my best to um, move along. I'll just share my screen right now. Okay, so the next presentation is to be taken by myself and my colleague Chimezie, who spoke earlier, is on the field in Imo. So now on the terminologies. I'll try to be very brief, and in as much as this would be shared, the slides will be shared afterwards. But I'll try to focus on the try to do this so save time. So on the terminologies, case definition. So this is basically a criteria set of standards for classifying whether a person has a particular disease, syndrome, or health condition. So this is just for us to, know that. So we always, for every outbreak, you'll notice it's very, very consistent. Whenever NCDC is responding to an outbreak, we always have a case definition. It's one of the information we put out to the public, to healthcare workers, so that they know how to identify if a person has a particular condition or not. Dr. Disu mentioned that for the COVID-19. So case fatality ratio, I think this is quite straightforward. It's basically, it gives the proportion of cases, and it basically explains the severity of a particular disease outbreak. So preparedness is quite straightforward. I'll just move to the next one, which is an emergency operations center. Please call my attention if I'm a bit too fast. So the EOC for short is a physical location for coordination of information and resources to support incident management activities for any type. So this is basically a physical structure to help coordinate a public health emergency. In this case, for the COVID-19, states and all states, or rather almost all states, had emergency operation centers that was used to coordinate this outbreak. So we have partners, relevant stakeholders, every decision maker that is relevant in managing an incident, all come together in a room, which is set up with necessary infrastructure to manage an incident. So NCDC actually helped over 20 states set up EOCs. That's part of the subnational strategy to support states. So moving ahead, epidemic, pandemic is pretty much straightforward. Public health emergency is a group name for all disease outbreaks. So public health emergency, it could be a disease outbreak, it could be a fire incident, a fire outbreak, or whatever is a collective name. Public health emergency of international concern is an extraordinary event which is determined as provided in the international health regulations. Now, standard operating procedure, SOP. So I think this is quite straightforward. Epidemic call, EPICAL. So it shows the progression of illness in an outbreak over time. So since the beginning of the COVID-19 outbreak, NCDC published the situation reports. And in those situation reports, they are actually on the NCDC website. You see that it has EPICAL. It shows the progression of the disease, whether it's increasing or decreasing. The novel coronavirus, the institutional quarantine. So it's basically restriction of activities when they are not ill with COVID-19 for the purpose of protecting unexposed members of the communities for contracting the disease. So, I mean, this is basically quarantine. Institutional is just descriptive for this. Self-isolation, quite straightforward. Social distancing, or, well, physical distancing, very straightforward. Now, NCDC only
Hello, Emeka, we can't hear you.
But so we have the website, we have the microsite. So just like so many other countries, NCDC now dedicated a particular website, a microsite, for all information on COVID-19. So this includes the daily situation report, which is now weekly, uh, includes every press release that we have, public health advisory, and guidelines. It can all be found there. So I think this is something you can get acquainted to post this training as well. So I'll hand over to Chimezie, my colleague, to take us through the next session. Thank you so much.
Hello, thank you very much, Emeka. Can everyone hear me? If you can hear me, just put a
Yes, we
yes on the
can.
chat
Chimezie.
section. Oh, okay. Okay, thank you. Okay. So next slide, please. I just want to quickly take us through some of the informations that we'll put up on our website that might be a bit technical and for people not to understand. I just want to take us through them and just try to define what some of them means and some of their implications so that whenever we are using them in our media houses, we also understand how those things came about. So on the websites Emeka has just mentioned, on some of those NCDC owned media platforms, we usually put out a lot of information from time to time. It's good that people understand these informations and how to use them. So one of the things that we put out during the course of this outbreak is a community case definition for coronavirus disease. If you remember initially when we had that outbreak and we didn't have the community transmission, we were not in the community transmission phase, we had a case definition for COVID-19. And that case definition included travel history to an international country or to a state where we currently have the outbreak. But as we progressed to the community transmission of COVID-19, we developed a community case definition to enable health care workers and even the general public identify whether they have the disease, if they're a suspect case, a probable case, or a confirmed case. So what is projected on your screen is currently our community case definition for COVID-19. And these are the criteria to describe if you're a suspected case: anyone who has cough and or fever, or history of fever in the last 2 weeks with one or more of these symptoms, shivering, shaking, etc. You know that you're a suspected case. You need to go and get tested to confirm if you are positive or not. A probable case remains any person that presents with any of the above symptoms in the last 2 weeks and died without a confirmatory COVID-19 test. There is no way we can say someone has COVID-19, even if you show all these symptoms. There is no way we can tell if you have the disease or not if we don't conduct a test and confirm the presence of that virus in your body. So a confirmed case is only any person with laboratory confirmation of SARS-CoV-2 infection with or without signs and symptoms. So you don't necessarily need to show signs or symptoms. As far as you are tested and it's confirmed that the virus exists in your body, it means that you're a confirmed case. Next slide, please. So, it's also good for us to understand what these other categories are. A contact, when do we say someone is a contact case? Is also a person who experienced any one of the following exposures during the 2 days before and the 14 days after the onset of symptoms of a probable or confirmed case. So you have to be able to show this, you have to be able to have been exposed during the 2 days before and 14 days after the onset of symptoms of a probable or confirmed case. So if you're exposed to anybody that has the virus 2 days before or even 14 days after the person started showing symptoms, you are a contact. So if you have a face-to-face contact with a probable or confirmed case within 1 meter and for more than 15 minutes, you are a contact. If you have direct physical contact with a probable or confirmed case, you are a contact. If you have direct care if you directly care for a patient with probable or confirmed COVID-19 disease without using proper personal protective equipment or other situations as indicated by the local risk assessments, you are also a contact. Being a contact does not mean that you are a confirmed case. It just means that you are likely to have been exposed to the virus. So what happens is that right now the policy is that all contacts should be tested. If you're tested and it's confirmed that you don't have the virus, it means you're no longer a contact. You don't have the virus as at that time. So next slide, please. And it's also important to point out that contacts might be asymptomatic, which means that you might not be showing any signs or symptoms, but you have been exposed to someone who has the virus. So we also publish a situation report. Currently for COVID-19, we publish a daily situation report. There are diseases where we publish weekly situation reports. In fact, there are also diseases right now that we don't publish situation reports for, and we will find out why that's it's happening. So a situation report actually, hello. So can you hear me?
Yes, we can.
Yeah, so a situation report is actually a message that provides a summary of a situation to designated decision makers. It's actually something that we provide to decision makers to enable them decide what response activities they should carry out, what exactly is happening, how many cases do we have, and all that. And one important thing about this situation report is that every information contained in a situation report is verified. It's actually a factual information that gives you explicit details, and it follows the rule of the who, what, where, when, and how. So it provides all those details: who and who have been affected, what exactly is the situation, or what exactly is affecting them, where are these people, when did it start, if it can, it provides details of why, and also how. So that is why it's important for us as media personnel, as even the general public, to always look at the situation reports of diseases that are being published. It helps you understand where we are, what's the number of cases, but not just that, it also helps us understand what level of response are we putting in place for that incident. So, and this is not prepared by just anybody. It's prepared by subject matter experts. They are the ones who create CTREPs when there is an incident or potential of an incident. And it's usually done within a short timeline, and is published when there is an outbreak, right? It's usually up to date. That is why I said that there are some diseases right now that we don't publish situation reports for, and there are some that we publish situation reports for. So if we're in an outbreak, we are in a situation where there is potential to be an outbreak, we publish situation reports. And we look at the risks and the potential of the disease to escalate. It helps us determine what frequency do we want to be publishing the situation report. Is it daily? Is it twice daily? Is it once daily? Is it once weekly? Is it once monthly? Etc. So next slide. If you look at the COVID-19 situation report, if you look at the COVID-19 situation report, you will see how it's been broken down. It actually has 7 different headings. It provides a highlight. That highlight actually gives us like a summary of what exactly has happened. That is where we see the total number of confirmed cases on that day, the total number of confirmed cases for the week. It shows us if how many states have been affected. It gives us the names of the states, etc. We also have where we have the situation updates, where it summarizes the data of samples collected, confirmed cases, affected states, discharged cases, and confirmed fatalities. So this is where we have those informations. And also, we have the category where we look at this, the state of the nation. So this actually provides us like a brief overview of everything happening in the country. How many cases do we have in each of the states? How many people have been discharged in each of the states? How many people have been tested in each of the states? Now it breaks down and gives us a nationwide picture. Apart from that, we also have the fourth category where we have a general fact sheet around the outbreak. So this actually gives us general information about just breaking down really about who and who have been affected, how many women, how many men, general facts about the disease, etc. And it gives us current data. Apart from that, the fifth category is where we have selected charts. So we now put the data in a way where it can be appreciated for that people can look at it and just make quick sense of what we are talking about. It will provide a chart showing all the states that have been affected, all the states that have over a certain number of cases. It gives us how many males have been affected in a chart. So you can look at it and quickly know how many cases we've had in each of the weeks. And also we have the heading where we provide what are the activities we are doing as preparedness. So preparedness really in anticipation of all the issues that will be coming up, what are we putting in place? And the last category is our response efforts. Given the issues that we are facing, what response are we mounting to the outbreak? So that is where you see we provide information around the labs that we have set up, how many people we've trained, rapid response teams that we have deployed to states, and what we are doing around communications and other pillars. So this is just a brief summary of what is presented in the COVID-19 situation report. And it's important to note that we have been publishing the COVID-19 situation report on a daily basis since the beginning of the outbreak. The situation report have been published on a daily basis. But I think there's going to be a shift in the coming days. We're trying to move from the daily publication of the COVID-19 situation report to a weekly publication of the COVID-19 situation report. It still does not mean that we are no longer in an outbreak mode. We are still in an outbreak mode, but from our assessment of how we should move further, we are likely going to start publishing the CTREP now on a weekly basis. So next slide. Next slide. So it's just for us to appreciate some of the things that I've just mentioned. If you look at it, you see some of the things I've spoken about. If you look at the state of the nation, you see the map showing the whole of the country and looking at who and who have been affected more, etc. I don't want to go into this again. You see the epidemiological curve on the top right, which shows us how the disease has progressed from the first day of confirmation of the outbreak in Nigeria. So these are all the things that we can look at and appreciate the response. So the slide showing now on our screen is actually the weekly epidemiological report that is published every Tuesday. We've been publishing this since 2016, every Tuesday, every week. There's no week that we have missed publishing this weekly epidemiological report. What this is that actually we collect routine data of different diseases across the country. You know, this is how we actually monitor when we are in an outbreak or when there's something we should look out for or not. This weekly epidemiological report is collected whether there is an outbreak or not. This is something that should also, all the trust issues that we had at the beginning of the outbreak that people started saying, we are just seeing NCDC, what have you people been doing since, when you go at the weekly epidemiological report that we've been publishing. Hello?
We can hear you now.
We can hear you.
Okay, sorry, I was just cut off. for a bit. So when you go back to look at the weekly AP reports that we have been publishing non-stop every week since 2016, that will be an indication to show that there is an agency that has actually been monitoring outbreak trends and what exactly is happening and mounting the appropriate response. So if what happens is that the AP week starts on a Monday, and from all health facilities in the country, they look at the number of diseases that are presenting in each of their health facilities, and they collate everything and send it to their local government disease surveillance and notification officer. This disease surveillance and notification officer is like the disease surveillance person in the LGA. It goes around all the health facilities to collate all these things and sends it to the state epidemiologist. The state epidemiologist collates everything that is coming from all the local governments that have collected from all their health facilities. When they've collected all these trends, they analyze it to see what exactly is happening in each of their local governments. If they start seeing any indication of an unusual increase in a number of particular disease or symptoms, that is an indication for them to start responding. And they also each state sends all this data that they've collected to NCDC. So NCDC collates all this information coming from different states, the 37 states of the country. NCDC collates this data and also does their own analysis to find out where we are getting more and more reports of a particular kind of disease. So this will determine if we should start responding to it, if we should start preparing, what exactly we should start doing as regards that particular disease. And NCDC publishes this every Tuesday on their website. One of the things that we have noticed as a flaw around this weekly AP report is that sometimes it's delayed because of the process of collecting the data. It comes from the health facilities. It actually does not get to NCDC on the same day. It goes to the LGA the next day. LGA collates and sends to the states. States collates and now eventually sends to the national. Before national analyzes, it takes a bit of a time. It takes some time. So what has happened is that right now, NCDC has digitized surveillance structures across the country. What is happening now is that we are more or less having like an immediate report from health facilities. So health facilities, as soon as they are reporting to the LGA DSNO, the LGA DSNO is getting it, the state epidemiologist is getting it, and also NCDC is getting it. So this actually has helped us just hastened the decision-making process around response activities in the country. And this is one of the wins that even COVID-19 has helped us achieve. We have been doing this even before COVID-19, but COVID-19 actually, we use the opportunity of COVID-19 to now digitize surveillance structures all over the country. So that's actually a win from this COVID-19. So just to point out what is actually shown in the weekly AP reports. So we see a summary table showing the number of reported cases and deaths up to date for each priority diseases. We see a commentary or message on a given disease topic, a given disease or topic. We see a report of more than one disease. Because it's a weekly AP report, we see different reports of diseases. What's the situation of cholera? What's the situation of meningitis? What's the situation of Lassa? What's the situation of Ebola, if there is? What's the situation of all the diseases, the ones that are being reported and the ones that are not being reported, states that are reporting and states that are not reporting. So this is also what we can use to hold our different states accountable to say, are you reporting? Are you not reporting? Why are you not reporting? And then we'll push our public health officials to do what is right. So the picture on the top right shows how it appears on our website. Next slide. Next slide, please. So I've gone through this. So just to point out again, on our website, we usually publish public health advisories of different diseases, Ebola, cholera, meningitis, COVID, etc. So it just provides some basic key messages to the public around an emerging or an ongoing outbreak to enable people make the right decisions to protect themselves. So we'll give you an information around a particular disease. How is it spread? What are the signs and symptoms? Where can you get help? What do you do to prevent yourself from getting the diseases? What do you do to prevent your loved ones, etc.? When you have the disease, how is it treated? Where do you go for treatment? So it's published also on the NCDC website. It is shared also on our NCDC social media platforms and sent to members of the press. Next slide. Next slide, please. So no, just go back a bit. Go back to the other slide. Okay, so next slide. So you ask yourself, what is the usefulness of all this information to the media? Next slide, please. Yes. So what's the usefulness of all this information that we have presented here to members of the media? How are you going to use it? What should you even use it for? So it helps you to, obtain accurate information for your publications. When you look through the website and see all these publications that NCDC puts out, it helps you, have the accurate information, to put out there. It also helps you to look at human angle stories, to push out, who are the people that are most affected? Where will you see them? To also listen to their own original stories, and also you can use the data to do like a thought force effect, really to advocate for health quality improvement. If you look at the weekly epidemiological reports, it can present you with the data of states that are actually reporting. You see a situation where so many people are dying in a particular state. NCDC does not have the information they need because a particular state has not reported. If you look at the weekly AP report, it helps you understand who are reporting, and you can now hold them accountable to report. It can also help us develop contents that will be useful to specific audiences. It helps you stay abreast with the latest information and also to get deeper insights into the outbreak. We do a lot of analysis of these outbreaks, what exactly is happening, who is affected, why is it affecting them, researches that we are conducting. So when you look through these things, it helps you get a deeper insight around the outbreak. Gives your reporting more context and just an accurate information to put out there for the public. Thank you very much. Next slide. Next slide. Hello, next slide. Thank you. Okay, thank you very much.
Hello, please. I have a question, please.
Okay. Yes, Mukta, hold on, please. Emeka, can you hear me? Okay. But so I want to just confirm that either Emeka or Dr. Diso can hear. Dr. Diso, can you hear, please, sir?
I'm not sure they can hear you, but I'm here.
Mukta, is your question?
I can hear.
All right, great. So Mukta, go ahead with your question, please.
Okay, thank you, Dapo. My questions will fall in this angle. I think at the cost of doing the program to make a complaint about he has taken the test from one designated a collection center, and they told him 48 hours and he's yet to get his result. Now, to just confirm that, I myself took the same test on Sunday and they told me 48 hours. And till now that I am speaking, I've not gotten the result. I called the toll-free line, follow up, do whatever. Still, I'm yet to get the result. So I don't know. How can we be getting that kind of information? What is delaying the results so that people will be aware of this? That's my question.
Okay, thank you. First, we need to understand the process for doing the test. It starts with sample collection, and this sample will be sent to the lab, and then when it gets to the lab will now run the test, and then when they run the test, then the results will now be shared back to the states that sent the state epidemiologists that send the lab. So what happens is when samples are collected, it also depends on where the samples are collected from. And in some cases where the location is far away from the lab, because of logistics, the states are directly in charge of sample testing, collection. And in some places, they may want to batch the samples they've collected to a reasonable number before they transport them to the lab. It varies from state to state. So I'm just giving you the picture of what happens. Now, when it gets to the lab, it doesn't take more than 2-3 hours to run the test. But the machine, you can see that Chimeze was talking about the machine they have in Imo cannot run more than 60, and they have samples for over 200 in a day. For instance, if you are in that state and you collect your sample, and then they collect samples every day over 200. So you can see, you don't know when it will get to you. If they start from day one and you are donating your sample on day 10, they've had 60, if they do 60 per day, and they have 140 spillover every day. You understand my point? So that alone, because of the capacity of the machine, and then the personnel that are doing these tests too, they have to, if you understand the procedure, what it takes to do this test, the sensitivity of any error you make, the concentration it requires, it's not just anybody that will do the test. So it has to be somebody that is trained, well supervised. So it's not something I can just replicate that, 20 people, anybody, for us to get results on time. Now, another thing about that kind of machine is, all the parameters, variables that they collect about the individuals to do the test, age, sex, address, identifier, they give everybody a specific number. So many things like that. If the test is so sensitive that when they want to run the test, if those information, if they are not complete, the machine will not respond. Do you get? That is why they always insist, when they collect your sample, there is a form they call case investigation form. That case investigation form, there are a lot of questions that disease surveillance officer will ask. And sometimes people don't provide some of those information. Sometimes the people collecting the sample, it may be their error. It may be that they forget to collect certain data. Or it could be a mix-up. Because when they finish the test, they label, they write the name, and they transport them. So now those are the challenges that the people in the lab. So when they even run a test, let's say by the time they pull the data and they collect, they will now enter the test and the results. Hello, can you hear me?
Yes, we can hear you, sir.
So they will also enter the result into a logbook, because they have to document it before they distribute to send to people that have it. So now when it gets to the lab now send the results back to, when they finish, to the state epidemiologist. It is the state epidemiologist now that will now communicate the result. Sometimes the problem is with the state epi team. They might be the one that have not sent it, and they may have various reasons why this is happening. It could be that because people are overwhelmed with doing so many other things. Now we're saying COVID-19 is, Lassa fever is coming up in some cases. Meningitis this is December. We're entering the dry season and other diseases. And there are other things that they're still attending to. So sometimes they may think they have sent it and they've not sent. And when we now look at all these challenges, that is why NCDC, they are now going electronically, as in they want to do those things online. That when you do your test, they piloted it in Abuja, they are scaling it up in other states. How far they have gone with that is what I don't know, because it also depends on the readiness of the states to uptake that technology. When you do your test, when they collect your sample, they will give you a number. That number is your code, and everything your details will be entered online. Once they do the test in the lab, they upload it into that platform, and then you get an alert. When you get an alert that your test is ready, you will be required to upload that code. To fill in that code that they gave to you. It's specific, it's unique for you. When you put it, then you get your results. You can even print it out. So in order to bypass those logistics, the bureaucracy of getting the test back down to the people, to the people that own it. So the problem will come from when they collect the sample before they transport it to the lab where they will do it, because sample collection sites in most cases are different from where they do the test. So it now depends on the logistics. Sometimes the state might say, oh, it's the local government that is responsible for transportation of the sample, or the state. It depends on the arrangement in that state. So it depends on the arrangement in that state. That is one. Sometimes the problem might be coming from the lab themselves, capacity to handle what is coming in. That is why we continue to encourage more labs coming up in the state. But you cannot just accredit any lab that is not up to standard, because it takes a detailed, thorough, careful process for all these things to be done. So that might be the reason why you may not get the test within, we say 48 hours. We're getting 48 hours when the number of people that's at that time in the beginning of the outbreak were not so many that they can just say they want to run. They want to that the numbers that are available. So the demands was not so high then. They quickly do that and you get it. So a lot of issues, but I think gradually they are improving. Unlike before, where people will not even get tests. Right? Some people don't even get test results, and they will get frustrated. But now people are getting it, and turnaround time is being reduced. So that is it. Then what you can now do is, which state are you in?
Is in Abuja.
Which state? The person that in Abuja, okay.
Is in the FCT.
If you give me your details, I can call the state epidemiologist. If the result is with her, she might say, oh, if it has gotten to the state, maybe the person that is responsible for dispatching it is the one that has not done that. Then they can say, oh, it's ready, and they can then send it to you. If it has not gotten to her, they can now find out where is it. If it hasn't gotten to her, it means it's still in the lab. Maybe the lab is still working on it also. Or then you can find out what the problem is. But that 48 hours, now you may not get it exact 48 hours. But now I learned that the process, since we are opening up more labs, more private labs, and more lab networks, and then it's improving. But I will find out. Maybe after this, just send your detail. Let me contact the state epidemiologist for you. Thank you.
All right, thank you, sir.
Okay. All right, Dabo, sorry. Please, you have the floor.
Thank you, Emeka. So I just wanted to ask, who else has more questions? This is that time for questions and answer. Questions to ask them. This is NCDC. So whatever questions you have, please let's ask them directly so that we can be better informed by the time we are going back to engage citizens. And that's why we're having this conversation. So more questions, please, let's ask them. Bumi? We can't hear you, but I see your mic is on. Okay, all right, we're waiting for Bumi. Who else has more questions? Please go ahead.
Let me clarify something. You remember that story of the guy that went to Sweden? Hello? That went to Berekete family, that complained about him paying money, and the result did not come out. He paid twice. They are asking for money. They are doing that. And it went viral. I just want to a confirmation whether
Yes,
some of us.
yes.
Okay. Now, it's good that we understand this. Nigerian protocol says that you do test before you come in. You should be negative. Now, when you come in, 7 days after your arrival, you should repeat the test. And it is mandatory, you must pay for it. Maybe Nigeria wouldn't have done that if in March, our citizens that were coming back to the country and self-isolate, we would have trusted them that they would do the needful. Now, Nigeria doesn't want to take chances. Now, they say on the portal, when you are filling, they tell you that you must do isolation for 7 days at home when you are in the country. It is when you have done the test, you are negative, that you cannot start going out. So, which means if you are coming to Nigeria, you should plan nothing less than 10 days. Whatever you want to do, you factor in the 7 days you are supposed to do isolation for you to do the test, right? If the program you want to do is on November 17, that means you should have been in Nigeria by November 10 or November 9. So that by the time you do your test, they say you are negative, then 17, you can step out to go and do whatever you want to do. But the guy came into Nigeria on the 10th. On that 10th was on Thursday. And he now went to the lab on Saturday. 7 days, you are supposed to be at home. He's not supposed to appear in the lab until the following Thursday. He went on Saturday, that is the 3. He now started saying he wanted to do his test, the lab they sent him to. The lab said they don't have your details. The way they do it is they will only send your details to the lab when you are due for the test, so that the lab will not make mistake of testing people on day 3, day 4, because the purpose will be defeated. If you're supposed to do it on day 7, we're hoping that if you carry the virus, by then you manifest. If they do it for you on day 3 and you are negative, on day 5 you can still be positive. You may turn out positive. Then you will have said you are free and you will start carrying the virus around. So the guy broke protocol by even going on Saturday, day 3. Now he's saying that he wants to return on Monday back to Sweden, that he will lose his job. It is his fault. Because if you know that your job is so important, why did you come to Nigeria? This time around, Nigeria should not say because individuals have something they must come and do in Nigeria. They will not put the whole country at risk. That's exactly what happened to us. That's why we are where we are today. So it's either you choose your job, you stay there, or you delay what you want to come and do in Nigeria, or you come to Nigeria, you just make your arrangement. Because the country protocol is 7 days. I remember when they were asking that there are some people, even some officials that will come in for 3 days, they have workshop, even if it's a diplomatic activity, for 3 days, they need to go back. The PTF, they said, no is no, it's 7 days. If you can't spend less than 7 days in Nigeria. Even you should even be planning for like 10 days, because 7 days, you're not supposed to even leave your home, unless what you want to do is online platform. You can do it on online. But 7 days after, that is when you now go and do your transact your business. So you should be thinking of like 10 days and above if you are coming in. So maybe the communication, maybe the message the guy received, he was not properly told, or he was told, he just felt that it can be the system. You know, Nigeria sometimes. So it's like crying foul when the system says 7 days. You go on the 7. So when you get to that lab on Saturday, the Saturday that he got there, the lab said, we have not received your details. So to him, it is fraud. He has paid. The information has not gotten to the lab. And that was deliberate. Because when you even pay, the money goes straight to the bank. The bank will process it. And that thing was even a private arrangement. It is not even government that is fully in charge of that thing. It was just posted on the site of NCDC. Because the federal government felt, PTF felt, people that want to travel, they should not come and burden the system, the limited resources for people that are sick, that the system is supposed to take care of. So for public utilization, for people who are sick, this test is free. But if you want to travel, and in order to safeguard Nigeria, then you need to factor the cost of your test into that trip. And I mean, you will factor it into your trip cost. If you think it is necessary for you to travel, we did 6 months that they closed the airport and nobody traveled. If you think so, you should be ready to bear the cost. So that is why they now say, okay, let private sector organize it so that they won't say government is sitting their money. The banks are in charge. The banks, they are the one that carry out the transaction. When you pay, it goes to the bank. It is the bank that will now process and send your details to the lab. And then the arrangement is the bank will remove their commission. The lab will remove the lab that is going to, they know the cost of whatever it is. And when they are saying a 30,000, 40,000, when I looked at in America, just do research, what is the average cost of this test? They say it ranges from $27 to about 3,000 US dollars. A test. On the average, it is $100. $100. For that $27, it has been subsidized for sure. So if lab is going to do it, government is not going to put in their fund to fund people who are traveling, people who have the resources to travel. If people, poor man cannot say they want to travel, right? So that is the arrangement. That is why that the national private sector, CACOVID was actually at the center of that arrangement. But CACOVID is a private organization. They cannot host this thing to the world. I mean, it's because it has to be hosted on government, whatever. That's why they hosted it on NCDC platform. Because the results will still come back to NCDC. NCDC will still need it to drive action, policy, intervention. And that is why NCDC, there's an interface with NCDC. Do you understand my point? Where, like, okay, at some point they need to know. So that's why you see that they respond. When people are saying NCDC is just collecting money, it is not even NCDC. The staff that collected that money, that collect the money, they are private staff. But the only thing is, the people that will check your records to see that, okay, you have done the right thing when you are coming to into the country. They are point of entry, Federal Ministry of Affairs staff who are working at the point of entry, who are not even NCDC staff, but because you're all working in collaboration. Ministry of Aviation, they have roles to play in this. But NCDC cannot start coming out to start telling the whole world that this is people, it will complicate matters. But what we are trying to do is see how we can resolve that issue. When they escalate challenges people are facing when they want to fill the form, when we pick it up, we send it to the people who are running the portal. It is not even NCDC that is running the portal. Do you understand me? I'm saying this for us to understand so that when Nigerians come, we will be able to educate them. We will be able to, the guy that broke the protocol, when we went to the Berekete family radio, if the Berekete family radio has the information, it will have asked the guy, you are the people that want to put Nigeria in trouble. They say stay 7 days at home. Day 3, you came out, you are looking for, and your details are not yet there. Do you understand my point? But he started crying. He wants to listen to, what kind of country is this? You can say that it is not fair to Nigeria. It is not fair to the system. It's not fair to Nigerians doing that. So we have our errors because that lab too, because of his pressure that is going by, is using, the lab has to say, okay, unless you want to do another test, you have to pay. That was when he had to pay to take that test sample on that Saturday. They were not supposed to collect that sample from him because those, do you get? So later, the original money he paid, they now send the text message to him that he should go to that place to do the test. That was when he now said they asked him to go and pay another money. No, that is the message you now receive when he is now due, but because he has taken the test. So it's good we understand, and because somebody mentioned it earlier that people were calling, making calls, it's because if you don't have the right information, you will not be able to respond. And then the people, the media, the people where this thing happened, they did not contact the right authority to find out that we have a complaint here. We are just hearing it on here. You don't even know where you will get the guy. The guy has not gone to the appropriate place to go and tender his complaint. So those are the things that we identify our gaps. So we are also putting measures in place to ensure that proper communication is made to everybody when they are feeling it. This is the procedure. This is what you need to do. This is what you need to do. There are other people too that have been accessing this system, they don't have any problem. You can corroborate what I'm saying. He said other people on the same flight that went to the lab with him couldn't find their name because it was not yet ready. They won't send the details until like Wednesday, Tuesday on Wednesday, to tell them that tomorrow or next tomorrow, this person is coming for test so that the lab can prepare for it. If they send it too early, the lab may do the test when they are not supposed to do it. And because the people can put pressure on them, and that is risky for the whole country. Thank you very much. Just let me clarify this issue because it was raised earlier. I think you have the right to know what is happening.
Thank you so much, Dr. Disu. Actually, I think that was very, very needed. It was one of the most burning topics that a lot of people have raised, not just on this platform, but all other trainings that we've had. We've noticed that this is one of the wrong perceptions and leading to mistrust in the system and the public health response. And it's very, very good to clarify such. In fact, I'll also make one more clarification on a very, very a commonly raised issue as well that has been brought to our attention. But just to thank everyone, use this opportunity to thank everyone. We are working towards closing at 1 p.m. or even before 1 p.m. if we don't have any further questions again, but we will not go beyond 1 p.m. And I've just put my number on the chat box once again. I'm Emeka. I manage media relations for NCDC, and we maintain a very good network and engagement with journalists nationwide. Opportunities like this we use it to update our database and welcome new colleagues onto our infectious diseases within our mandates, including COVID-19, and also help as much as possible in any way where our help is needed. That's it, and we are still taking questions in the chat box. And just like I mentioned, as regards another clarification, so if you could recall, if colleagues can recall, a few months ago, there was a lot of people came down on NCDC for announcing over 11,000 discharge from in one day. And in fact, it was a source of uproar. A lot of people stopped believing what we are saying. Anytime we make posts after that, a lot of people will say that yes, they always knew that we are lying. They always knew that the figures were false. That imagine they even announced 11,000 cases in one day, and 11,000 discharges in one day. And just to mention, like what Dr. Disu said, right? From what Dr. Disu said, you see that yes, we would always acknowledge where we've erred. If there's any flaw from our part in the public health response, it would always be acknowledged. But we've always committed to stating the facts at every point in time. Okay, missed it, Margaret. Would you like to speak? Okay, since Margaret wants to say something. So I'll just be very quick since we have till 1 p.m. And it's just to call to attention that there's always a perspective from the accused, right? Beyond the accuser. I mean, I think that's our responsibility, to ensure balanced reporting. And about that 11,000 discharges, right? Nigeria.
Emeka, we can't hear you again.
Develop.
Oops. Okay.
Yeah. Sorry. Hello.
Yes, Emeka, we lost you at some point.
Okay.
Yeah.
Okay. So I was just saying that. Let me just try to round up. So NCDC in leading the public health response, so that this was a challenge, right? And in trying to mitigate this, developed a strategy and a document, a guideline is still on the website on home management of cases at home. The Lagos also did the same, and this was agreed upon as a country, right? So at some point, those cases that were being managed at home or called managed in the community, whichever word you want to use, they were not reported they were not part of the data reported on a daily basis by NCDC, right? Because it was a new technique to manage cases. And you know that these cases are managed primarily by states. States have the mandate to provide clinical care, while NCDC focuses on the health of the population as the National Public Health Institute. So when it got to a point where there was a large backlog in the number of cases that were managed at home, NCDC had to work with states to have a consensus on the way these cases would be reported. And this was done, this was announced, and that was why when those 11,000 cases were announced, we added a caveat in our announcement on Twitter that these were cases that were managed at home over a period of time, right? And a lot of what we saw, one of the lessons we've learned is that when announcement is made, when an information is made, right, a lot of people do not try to get to the root of it to understand why such announcements were made, and to also listen into subsequent follow-up information to further explain such scenarios. It never is done. People run off with the little bit of information they get, whether it is from social media or conventional media, or even the source, the authorities. So, I mean, I believe Dr. Disu has made the point of, urging colleagues to always look out for news from authorities, right? We are not saying that we are always right, but we are saying that we have the responsibility to focus on the facts, which is the health authorities. And sometimes we've even been called, our attention has been brought to some mistakes that we might have made, and it has been corrected. But a lot of people do not bother to, look at this or see how the authorities try to provide clarity on such. So that's my quick comment. Thank you so much.
Right. Thank you, Mika. So back to us, and Bumi, you wanted to say something then. Can you go ahead and speak now? Bumi, can you hear me? We can't hear you, Bumi. Your mic is off, but we can't hear you. It doesn't show that you're talking. Okay, so I guess something is wrong. While Bumi is trying to get his mic to work, who else has a question for them that we can attend to quickly? Any question? We're rounding off very soon. Any question?
Okay, I want to ask Mukhtar Alilu. I saw what you sent, but I want to advise that you don't leave details like this on public platforms. Do you understand? I expect that I will give you my number and you send it to my text. But give me, okay. Maybe you have my number so that we can chat. There are some other details that I will require beyond this for us to be able to get the information. So I will ask you. Do you understand?
All right, thank you so much. Thank you so much, Dr. Yusuf. Please, I also wanted to add, in addition to putting my number here, one of the ways we've been able to really work closely with journalists is by responding to media inquiries. And we receive media inquiries almost on a daily basis, multiple times in a day, from journalists across board in the country, internationally, trying to seek clarification from. I'll send my question to Emeka later since my mic is active. Okay, that is Bumi. Okay, thank you, Bumi. So we receive media inquiries every day, right, on the public health response, from journalists across board, not just on coronavirus, even on Lassa fever, whatever the disease outbreak is prevalent at that time. And we try to provide these responses in a timely way, taking note of the being mindful of the timeline of the timeline from the what do you call it, from the media organization. Now, even though your of what you need. They will still direct you to myself, right? So it's we appreciate it, and we want you guys to always reach out to us for whatever question you have. Sometimes, in fact, almost 50% of the time, especially during this COVID-19, a lot of questions that came to us, you know, we are on things that NCDC does not respond to. That is, are things that are outside NCDC's mandate. And we also try to educate and direct the journalists as accordingly, right? To explain, what our role is, what our mandate is, and who you need to reach out to help. And oftentimes, when we have those contacts, we also help, put them in touch. So we are always open. We have we have a mailing list as well. I can see that some people have reached out to me on WhatsApp to add them to the journalist group. I mean, it's very much welcome. We have an email address. We have a mailing list where we blast our press releases when they're available on the web as well. These press releases are updated in real time. So we always, part of our success in NCDC is really dealing with them, is really getting enough feedback from people we work with, from our stakeholders, from the public. We use this feedback to improve on our work every time. So thank you so much. We have less than 10 minutes to conclude, and I'll hand over to Dapo here to continue. Thank you.
All right, thank you, Mika. Thank you, Dr. Diso. More questions, people? Any more questions? We have about 9 minutes. Questions for them?
As Mukhtar Alilu left the platform.
Yeah, I guess network must have yanked him out presently. But I would communicate that to him and send your number to him once I get.
It's not here, right?
No, it's not.
All right. Okay.
Yeah. So once I get your number, I'll just send it to him so he can contact you directly, sir.
Okay.
Yes. Okay. So it looks like nobody has any question, and we are all clear. In the absence of any question, once again, thank you so much to NCDC for doing this with us. Like I said when we started, the goal is to, as much as possible, pass across the right information, so we are not misinforming people or spreading fake news, and we can also curb them when we hear them. I know because it is radio, we can get very quick access to what people are saying in various communities. And that's really why we are doing what we do with this radio engagements in these 14 northern states. So please, you are ears. And the goal is that once you hear from people in your different states, communicate them to us. Now you have direct contact with NCDC, you have Emeka's number, reach out to him directly, let him know what the questions are. If there's a need for them to speak to it, they would address it. I remember there was that time where the chloroquine thing was rampant, and I immediately reached out to Dr. Chinwe because we had a meeting with her before then, just to explain or say something that people could reference, or just say something that we could say as well. And she did that. So once there are issues that you think need to be addressed, please reach out to them. They are NCDC. Those information you're getting online, wherever it's from them, so they can easily just debunk or clarify what you need based on the questions you get, and so that we can just say the right thing as they are. Please, coronavirus is real, as everybody had been saying. The numbers are we are still getting more people tested and more people confirmed. We are grateful that the numbers are not as high as they are in other places, but the message is still that it is real, and people should take necessary protocol. So please, we trust you to do the job in getting this done. We trust you to help us pass across the message very clearly and in very simple terms as well. So maybe, for example, people might see things online, on WhatsApp, on Facebook, that they don't understand. We expect you to help us break that information down and clearly communicate it to them. Again, to say that we know that there might have been challenges with getting guests. And what we've also tried to do is to have a few people from NCDC speak. I know we've done that in, I think, Kogi State, and one more today. I'm not sure if it's Kaduna. I think it's Kaduna, I'm not too sure. But our goal is to see how best we can get many of them to also speak in different states, and how we can coordinate that. But please and please, we trust you to do the job, and we trust you to get the right kind of people to speak. And we are grateful to partners that have been able to get government officials as well. I remember that in Kogi State, with the old drama, they were able to get the Commissioner for Health to come on radio to talk about what was happening there, which was really good. So please and please, we need those kind of engagement. We want to create that direct interface with government so people can hear from them. And yeah, and also because we know there's a trust deficit between even people and governments. And so that's why you're also there. So they are hearing from you. They know that you are not working for government, or like Emeka had said, they hear from a traditional ruler or someone like that they respect. They know it's not government. They can easily believe that person. So that's why we want you to please and please help us push word out, help us spread the right information. If there are questions, please ask. NCDC will respond to them, and we'll just keep doing this. And we trust that even beyond the 6 month period, we can get some more resources to continue, get some more resources to ensure that this does not end in any way. So thank you so much. So regarding the slide, yes, once I get from Emeka, I would send it to everybody so we can all have it and watch.
One thing I want to ask.
Through.
Sorry, one thing I want to add is how many of those partners are working with you? How many outfits, I mean radio stations, that through which you are reaching out? We would like that record for this.
Okay.
Thank you.
All right, sir. We'll send it. So 14 radio stations and 12 partners. So 14 radio stations in 14 northern states, and then 12 partners that manage the conversations. Now it should have been 14, but Connected Development Code have their staff in 3 of these states, Abuja, Taraba, and Kaduna. And so Code manages 3, and then other partners, the remaining 11. So that's it. So we would get the slides and send it to you so you can read through and get better understanding. If you have questions beyond this meeting, please reach out to me, reach out to Emeka, and we will take it up from there. Dr. Disu, your contact so I can send it to Mukta, or do I reach out to Emeka on WhatsApp? I'll check it. Dr. Disu has left. So Emeka, I'll beep you on WhatsApp to get Dr. Disu's contact. So once again, thank you so much, everyone. It was great having you around. Thank you. On this note, we would end this conversation. Emeka, any final words?
No, just thank you so much. I'm already adding some people in real time to the WhatsApp group. People have reached out to me.
Awesome.
Are we getting the slide via email? Please share Emeka's number again. I couldn't get. Okay, yes, it will be shared via email. I'm typing in my number in the chat box again. Thank you so much for the wonderful work that you're doing, and the entire EIE team and the leadership. You guys are doing incredibly well. I hope you find some opportunities to future on some of these radio platforms.
Yes, thank you. Lekon,
We are
my colleague Lekon, any word from you before we wrap up? We can't hear you, Lekon.
I'm fine.
Okay, Lekon.
Hello, can you hear me now?
Yes. Yeah, I can hear you now.
Yeah, I said there's actually no reaction or question. I'm fine. No.
Okay, great, thank you. And just to announce to everybody, please and please, all your inquiries should go to Lekon from now. I might not be available to respond regarding engagement on the radio and radio conversation, but please send it to Lekon. Lekon will be managing the engagement going forward, like we've directly has been calling you. Okay, so network yanking me off, but yes, go to Lekon. So on this note, thank you so much, everybody. Have a great weekend ahead of you, and please stay safe. Thank you so much.
Thank you, everyone.
So send your contact to Emeka directly, not on this platform. Send it to Emeka on WhatsApp so he can add you. Please send it to Emeka and not here on Zoom. Thank you. Bye, everyone.
Yeah, bye.
Bye.